above downwards. The right-sided massive pleural effusion along with underlying lung collapse along with SVC obstruction are right lung large SOL with SVC obstruction. Once the patient got admitted in our hospital, the routine investigations were done. The blood and serum parameters have been consolidated in this table. More or less, the parameters were within normal limit. Only in 2 reports on 24th and 29th of May, the creatinine was slightly on the higher side. Other routine investigations were followed, which showed that serology was non-reactive, sputum AFB and CBNAT was negative. Sputum culture showed confluent growth of Klebsiella pneumonia. Other tests were within normal limit. Digital chest X-ray was done, which showed a right-sided homogeneous. Digital chest X-ray peer view showed a right-sided homogeneous opacification in the right hemithorax. There is blunting of the right costophrenic and the cardiophrenic angle. The trachea is shifted to the right side. However, the lower mediastinum is not shifted. And moreover, the left bronchus here can be traced. However, the right bronchus cannot be traced after this point. Was followed by a USG whole abdomen, which showed that there is a presence of an 8.42, 3.47 into 7.84 centimeter cystic SOL, which has movable echoes within it. The Doppler showed the presence of yin-yang sign, which was probably because of an aneurysm of abdominal aorta. Moreover, the liver was enlarged. Bilaterally, the renal cortical echoes were raised. However, the CMD was maintained. Also commented about the presence of a right-sided pleural effusion. It was followed by CECT thorax, and the CECT thorax shows that there is right-sided massive pleural effusion. Along with that, the collapsed lung can also be seen, and however, there is no shifting of mediastinum to the opposite side. And in this image, the bronchus compression can also be appreciated. The video of the same. It was followed by a CT angiography of the thoracic and abdominal aorta, and here in these cuts, if we can appreciate, there is a well circumscribed circular lesion showing spontaneous contrast. CT angiography of the abdominal aorta showed the presence of a fusiform aneurysm involving the infrarenal abdominal aorta and also extending to the bilateral common iliac arteries. ECG 12 lead showed the presence of bradycardia. The pulse rate, the heart rate was around 50 per minute. Moreover, the P waves and QRS complexes are coming simultaneously, thereby suggesting the presence of a junctional rhythm. 2D echocardiography was done. Ejection fraction was 64%. Apart from the presence of mild tricuspid regurgitation, other findings were within normal limit. USG screening of the right hemithorax was done in our department, which showed the presence of a right-sided massive pleural effusion. This is the video of the same, which shows this anechoic structure present perceived in the USG, which is right-sided pleural effusion, and also this is the characteristic jellyfish sign. Pleural fluid aspiration was then done under USG guidance, maintaining aseptic conditions. Pleural fluid investigations were as follows. It was straw-colored fluid, had a pH of 7.45, was lymphocytic, exudative, had ADA of 6.4. There was no growth of any pathogenic microorganism on culture. M cell via cell block was sent in 3 consecutive samples, and it was negative for malignant cells in all of them. This was the image of the pleural fluid. Fiber optic bronchoscopy was done in our department, which showed that RMB is occluded by endobronchial growth. Multiple biopsies were taken from the lesion. The bronchoscopic biopsy report suggested that it's an invasive squamous cell carcinoma. Slide review was done in our department, which showed features of non-small cell carcinoma of lungs. BAL fluid report showed that it predominantly had polymorphonuclear cells. Culture showed no growth of any pathogenic organism. CBNAT was not detected. M cell via cell block was also negative for malignant cells. This is the image of the histological slides, and it shows the presence of sheet-like pattern of cell. Moreover, there is presence of abundant eosinophilic cytoplasm and a high nucleocytoplasmic ratio. These slides are viewed in 10x magnification. When visualized in 40x magnification, the cells again show the presence of abundant eosinophilic cytoplasm with large nucleus, and intercellular bridges are present, and along with the presence of dispersed chromatin, thereby creating a mosaic pattern. In the 40x magnification itself, this is the presence of an apoptotic body, which also indicates that the slide or the tumor has a high mitotic activity. So my final diagnosis is invasive squamous cell carcinoma of right lung along with right-sided massive pleural effusion, superior vena cava obstruction, and infrarenal abdominal aorta aneurysm. Radiotherapy opinion was thereafter taken, and they started the patient on external beam radiation therapy in view of SVC obstruction. He received a total of 10 such cycles before discharge. Moreover, he was prescribed the following drugs: injection Dexa, tablet torsemide, and tablet spironolactone from their side. Opinions from cardiology and CTVS department was also taken, who had prescribed a 24-hour Holter monitoring from their end because of bradycardia. Orsivest was also prescribed, and CTVS department suggested that we should go for an endovascular repair of the abdominal aorta aneurysm with high risk consent and after pre-operative anesthetic fitness. Very few case reports have been found, but recently in 2021 in the Journal of Vascular Surgery, a report was published which showed that there is a high prevalence of abdominal aortic aneurysm in patients with lung cancer. Both the prevalence and incidence of lung cancer is high in those patients who are being screened for abdominal aortic aneurysm. Thereby they are